couple days. I think my job is not to sort of draw any conclusions, but to just sort of, describe what the controversy is about, perhaps the data that really, was seen differently by the two sort of factions with different views. Those two controversies are the FDA's decision to issue an emergent use authorization for convalescent plasma. And NIH shot back with a panel statement yesterday, and we'll talk about that. Then the second one was also the CDC's decision last week to make a very controversial statement about testing. And we'll talk about possibly what was behind that. And what I'm going to do is really sort of, anyone please, sort of at the end of each of those discussions, we'll just have a dialogue and a discussion about what your thoughts are and how you see it. Again, my job is not to draw any conclusions or to take one side or the other. My job is, I think, to point out the controversy. And I think more importantly, given the controversy, decide, sort of have a discussion about what, we do moving forward. So if we can go to the next slide, before we get to the first controversy, I want to just start with one slide that was perhaps maybe only a controversy in my head, but several weeks ago, actually maybe longer than that, there was a statement that actually corticosteroids should be used, that they decrease mortality. And that initial data was interesting because the mortality in the group that did not get the steroids was much, much higher than we had seen other places. And I was, personally skeptical, but I wanted to present this. This just came out online in the last day or two. It's a WHO group. And it really took, as you see listed there, multiple studies looking at corticosteroids. A couple things to remember. The first study only had, sort of a small number of patients, though other studies had, a much, much greater number. Some of them used hydrocortisone, some methylprednisolone, and some dexamethasone. And you can see on this slide the separation of those three. But the important thing is really to look at the panel at the right, at the odds ratio. And you can see, with the exception of, sort of studies that had very, very, very small numbers of folks, which had then very large confidence intervals, the large studies really favor using steroids, whether it's methylprednisolone, hydrocortisone, or dexamethasone, as shown by the boxes that, as you look at the screen, are to the left of one. And I think that this is really clear, data, and I think we're starting to get better data in a lot of areas with COVID. But I thought that this was worth presenting because I thought it was a very nice, sort of analysis of multiple studies. I think it shows the effect and the problem with making conclusions with very small numbers. But when you get adequate numbers, it's clear there's an advantage. Reference, this has really been published online in JAMA as of this past week, and you can go on and read the whole paper. So I thought I'd start out with something that I don't see as controversial, but now we'll move to the first controversy. If we can go to the next slide. This shows in the upper right-hand corner, President Trump, Secretary Azar, and Commissioner Hahn making the announcement about the emergent use authorization for convalescent plasma. I'm not going to read you the verbiage there. This is actually from the FDA website. I would just point out, though, that they do say that adequate and well-controlled randomized trials remain necessary for definitive demonstration of efficacy and to determine optimal product attributes. So, I think that acknowledgement is there, but nonetheless, the EUA was made. If we can go to the next slide. This is also on the website of the FDA. The FDA just generally takes multiple different studies. They have very good statisticians that look at it. I don't know what studies they didn't say they were using here. I will present two studies in just a minute. But I think that the things and the themes that you should remember, if you look at the panel on the left, those are antibody titers. So a very, very high titer, greater than 1 to 2560, is really contrasted with low antibody titers showing lower to down, less than 1 to 80, 1 to 80. And you can see, if you look at the percent death, that actually those antibody titers that were associated with less death are really the high titer. And I think, look for that theme, because we're going to also, see that in at least one of the studies. I think on the right, they really sort of put it together and took, any antibody titer greater than or equal to 1 to 320 and compared it with lower antibody titers, 1 to 160 and below. It's interesting they took the cutoff at 1 to 320. I think it would have, if they had taken 1 to 640, it would have been higher, though there are smaller numbers and perhaps the confidence intervals would have been bigger. But you can see that the reduction in mortality is actually 37%. You might have seen in the news that there was some misstatement about absolute risk, being 35, but it was actually the reduction in the risk, the relative risk, that was 37. And this is on the website. If we go to the next slide, this statement from an NIH panel appeared yesterday. And they stated that convalescent plasma should not be considered standard of care for treatment of patients with COVID-19. And then below is a subsequent quote that says, though data suggests convalescent plasma with high antibody titers may be beneficial in non-intubated patients, uncertainty remains about efficacy and safety of convalescent plasma due to lack of randomized controlled trials and possible confounding. So therein lies the controversy. And I think, one of the questions to ask yourself, there are a lot of drugs, and actually there are monoclonal antibodies. There's a monoclonal antibody study out of NIH that hopefully will be opening here soon. And some of the exclusion criteria are getting convalescent plasma. And I think whenever there's an EUA, then, and I understand it, people feel, well, we really need to give folks everything we can, and it's an EUA, and that may actually disqualify people from participating in trials. On the other hand, you can understand the quandary for the patient, because a trial means that they may be getting placebo. So that is the question. I wondered in my mind the way this has classically been handled in other diseases, and this is just my personal speculation, but often what you do if you feel there's not equipoise for the patient is then have a control arm that is, for example, in this case, the high titer convalescent plasma. And whether that will occur, I don't know. I have not seen in the circles that I've been in any discussion of that, but I think that this controversy, will raise that question. Let's look at two studies, which is sort of what we have. The first, if we can have the next slide. This was a study done in Wuhan, and it was actually a randomized study, and it looked to evaluate efficacy and adverse effects of convalescent plasma. One of the things that individuals were worried about is whether or not the antibody could actually enhance the disease. There are precedents for that in infectious disease, particularly with dengue fever is the one that always comes to mind. The first episode of dengue fever is not bad, but actually the second is much worse, and it's believed to be by antibody enhancement. And that has really stymied vaccine production for dengue fever for years and years and years. There is a new vaccine, but it in some places, but it is also, being questioned whether the same thing is happening there. In this study, it was open label, multi-center. It occurred February to April. The thing that is the problem is they controlled the outbreak so well that they could not complete enrollment. So the planned enrollment was 200, and they could only enroll 103. So many of the endpoints are underpowered, and you have to keep that in mind. If we can go to the next slide. This was, and I apologize, I know it's a busy slide, but I just wanted, they assessed almost 150 patients. They ended up randomizing 103. Actually, after they had, randomized them, only one discontinued in one arm, and one was excluded in the placebo or the standard of care arm due to the fact that they had actually gotten convalescent plasma after enrollment. So that made for, sort of the 102 patients that they actually included in the analysis, 103 patients. If we go to the next slide. These were the baseline characteristics, and I think it's important to point out the median age was old. These are just the people that are more likely to die, slightly more males. You can see that the coexisting diseases are relatively balanced. There was a little more cerebrovascular disease in the convalescent plasma group. But that was the population, and I think that that's the population probably we're all concerned about. If we go to the next slide. And by the way, these were all hospitalized patients. Now, if you look at mortality in the convalescent plasma group, it was lower, 28.6% versus 35.7%. You might say, wow, that's higher than recent series have published. I think, remember, this was early on in the epidemic. And, that is really the mortality that they were seeing. There's not a statistical difference, but, there is clearly a lower mortality, and you've got to remember that it was underpowered. I think looking at the bottom of this slide, which is what is interesting, is if you look at the viral nucleic acid negative rate. So what percentage of the folks became negative at 24 hours in the convalescent plasma group? It was about 54% versus 17% in the control group. And if you look down by 3 days, it was 84% versus 34%, really suggesting that, at least to clear the virus, the convalescent plasma was having some effect. And if you look over at the right, you can see that those are statistically significant. I think one of the issues, however, you might say, well, wow, if it was working that well, why didn't we see a change in the mortality? And I think the other thing to remember is the current hypothesis is that much of the mortality and the organ destruction is immune mediated. And so, really after the virus has really set up that, immune cascade, really with going in and attacking cells with the virus and lots of cytokines, the antiviral is probably going to have less impact on mortality. If we go to the next slide. These are Kaplan-Meier's, which just make the point that if you look at those with severe disease, and severe disease was really defined as respiratory distress with greater than 30 breaths per minute, an O2 sat of less than 93%, and a PaO2, FiO2 ratio of 300 or less. You see in that group that there was some divergence of the curves. If you compare that with panel C at the right, life-threatening, these were people who were on ventilators, had shock, and really had organ failure, multi-organ failure, so it just could not be lung, it had to be something else. So these are the folks that we see, in the ICU ventilated, and there you can see that it had very, very little impact on mortality. If we go to the next slide. So that was that one. This is a study that is really the experience of the 3-month experience of the convalescent plasma study out of the Mayo Clinic. I want to caution everyone, what I am showing was pulled off of the web as a preprint. It has not been peer reviewed. Things are always likely to change in peer review. So I just want to, folks to know that. Nonetheless, it really, and this was looking for potential signals for efficacy. This was really a multi-center, open label, expanded access program. This was not a randomized trial. It was really, multiple centers using this because we really had nothing else. But it had a very large population, 35,322 adult patients. This is all folks 18 and over, who were hospitalized with laboratory confirmed SARS-CoV-2 infection. A little over half were in the intensive care unit, and a little over a quarter were on ventilators at the time of transfusion. And again, this took place from April through, I think, July 4th was the cutoff date. So that's the time we're looking at. If we go to the next slide. This is the adjusted mortality stratified by antibody level. And the stratification was really a lot. It was weight, gender, race, age, sort of being on a ventilator or in the ICU at the time of getting the convalescent plasma, whether individuals had gotten hydroxychloroquine or remdesivir or steroids or not. And so those were all factors that went into the adjusted mortality. The low, medium, and high refers to stratification of the antibody titer. And you have the 7-day adjusted mortality on the left and 30-day on the right. Do note that the y-axis is different. Obviously, the 30-day mortality would be higher. But you can see that there's quite a difference between, and it's dose dependent, particularly in the 7-day mortality. So I think that a high antibody titer is really important. And if we go to the next slide, this is stratified not only by antibody titer, but also by whether individuals got the convalescent plasma within 3 days of presenting or 4 or more days. And you can see quite a difference, both in the 7-day and in the 30-day adjusted mortality. So I think, one of the things that's really going to be key is I think people start putting together guidelines is it's very, very important to have antibody titer, to use high titers. There's a little bit of an argument, should it be high or, can you go with the medium? But I think that that's really a very important thing to remember. And if we go to the next slide. Oh, that's going to get us into the next testing thing. So just going back, I'm going to stop there and let folks comment. Again, those were, I think, the 2 best sources of data that I could find that were not just small numbers that I just presented. If we go back a slide, Mitra. And I think that the other thing to please bear in mind is that, the first one was a randomized controlled trial, but was underpowered, only enrolled about half the folks. So one would not expect to see statistical significance, though there was a very good editorial in JAMA when that paper came out that, said, yes, there appears to be an effect, even if you really account for it being underpowered. But it's really not the large effect that we saw, for example, in the 1918 epidemic or in the SARS-CoV-1 epidemic, back in 2003, where the impact of convalescent plasma was on the range of 50 to 70%. So I'm going to stop there. Do we have questions or folks that would like to comment?
Dr. Hodder, we did get a couple questions in the chat, but I'll wait to see if anyone wants to unmute and start a discussion first.
Would any of the other panel members like to comment?
This is Lisa Costello. I'm really glad you brought this up. I just prior to this was on a work group call with experts around our state discussing, guidance development for convalescent plasma use in West Virginia. And I think as we've learned throughout this entire process, we learn more and more. And this is the importance that we need clinical trials to be able to develop this information. But it does become tricky because I'm sure there's people on the call, as soon as that EUA was issued, members of the public were, where can I get my convalescent plasma? Or where can I get it from my family members? We ran into this with remdesivir. So it becomes, a matter of, and it goes back even further than that, goes back to hydroxychloroquine. So I do think when those type of actions happen, it then puts the public starts to want this. And I think as scientists and clinicians, we need to step back and make sure we're looking at the data and understanding where it's most appropriate for use, because certainly when it comes to convalescent plasma, it's a finite resource, and we need to make sure we're using it in a situation that may be beneficial as we continue to learn more, and using it appropriately, because I think anytime we give anything, there's a potential for risk. Someone did type in about, will children be included? At least nationally, there's not been indication for pediatrics with convalescent plasma. The clinical trial that is being run at WVU, the allergist immunologist is MedPeach trained, and his clinical trial does involve a pediatric protocol, but at this point, it's not been recommended for use in children. When I was on a national call about convalescent plasma, I think it still needs to be studied in that population. And I do not believe there's been any pediatric patients enrolled, but in the convalescent plasma study that's going on through WVU, but there is a protocol that it could be used for pediatric patients, but it's very low at this point in regards to enrollees in the pediatric population. So there's not any approved use in peds patients at this time that I'm aware of. I don't know if Dr. Hodder and other panelists are aware of, but my understanding is it's still not approved or recommended for use in children, although there are some clinical trials that involve potential enrollment of pediatric or younger aged people.
Yeah, just a couple comments. So the expanded access, the 35,000 patients was all 18 and over, no pediatric experience there. And the clinical trial, if I recall, from China was also adult patients. I neglected to mention, and I think it's important to mention, I did sort of say that there's a theoretical possibility of antibody-enhanced disease that was not seen in China. And to the best of my knowledge was not seen, though, we just have a preprint in the EUA. There were several transfusion reactions, which is, I think, to be anticipated. The two described in the randomized control trial in China were mild and easily managed. So I think that, the other side of it is its risk. I think we don't know if giving convalescent plasma then will abrogate or weaken the immune response. And I think that that's still a question that is out there.
Excellent, thank you. I can ask the first question, Dr. Hodder, if you'd like, that we got to the slides. So the first one we got in was, is there associated data showing complications associated with COVID other than death? Was there less MI, CVA, neuralgia, etc.?
Well, that is a great question. They did not comment on that in the Chinese trial, and I did not see that in the preprint, but I am sure that, that is going to be looked at. I think, the other thing we talked about a couple of weeks ago were these now chronic complications of unclear duration and severity. We talked about myocarditis and some of the encephalitis and so forth. And I did not see any comment about that. And I think that partly it may be because that's been relative, it's something new we're learning, but I'm sure folks are going to look at those.
Thank you. The next question we got was, most of the studies that have been done on CP unfortunately negate to list quantitatively the antibody titers in transfused patients. Do you think high titer CP is a good treatment option for patients with severe presentations of COVID-19 requiring ECMO?
I think the answer is we don't have the data to say that. I would say, that the study, the Chinese study that really had the Kaplan-Myers, it showed that once folks were on mechanical ventilation, convalescent plasma tended to do not much there. But this is exactly the reason that I think that randomized trials need to be done. So that's number one. I think the point about titer is clear. And, there was a paper a couple months ago in Nature Medicine that looked at antibody response. And interestingly, individuals who had the most severe disease got the highest antibody titers as opposed to those that had, mild disease or asymptomatic disease where the titers were much lower. So, I think that if plasma is going to be used, it should be titered. And the FDA, did make that point as well. I would say that actually what had happened in the expanded access is they went ahead and gave it, kept a vial, and then ran all those titers. So, they did not in a prospective manner sort of give high titer. This was really sort of after the fact, which has generated some of the bar graphs that I've shown. I mean, you've got to sort of think about it, though. You've got plasma donation, which is, sort of, not just getting a tube of blood drawn. And then if you're going to titer it, that has to be done very, very quickly. So it'll be interesting. I don't know, Lisa, if there's any discussion about that.
In regards to titers, I know nationally they were talking about that's been an ongoing challenge. And then, sorry, I was addressing a state health officer call, so I don't know if there was a more specific follow-up question that I may have not addressed, but if you share it again, I will give my best effort to add any additional comments.
No, you answered it. The question was about titer, and I said, I think absolutely that should be done. The problem is logistically, it's challenging.
Yeah, and I know that, so, okay, I was multitasking, I guess half well, but this was brought up on the national call where they had the director of Mayo's program that had been doing a lot of this research and distribution, and that was something that continually got brought up. I think it's, as you mentioned, it's a challenge in regards to adequate capabilities to be able to do that in a short amount of time. And I think that there was a desire that it would eventually be something that could be quantified and shared. But I think in the short term, it's been challenging to do that. And there were multiple people that commented on that, at least on this national call of over 500 people, blood banks, pathologists, clinicians, health departments, health officers that spoke to that. That makes it more challenging because we don't know, are the people who are doing better getting a higher titer or a lower titer? There needs to be, better identification of that.
I did not mention in the Chinese randomized trial that I showed, all of the convalescent plasma they used had to have a very high antibody titer. And here's the other thing that to even complicate it more. There are lots of different antibodies, you know, that can glom on, but neutralizing antibody is the antibody that really is felt to be most important. And actually, the Chinese study required a high titer not only, you know, to COVID antibody, but of neutralizing antibody. And I think that you know, may be why when I showed you that table where they sterilize the virus very quickly, you know, in several days, that may have been etiologic. These titers in the expanded access experience were just overall antibody titers, not, you know, neutralized antibody.
Excellent, thank you. So we got a question asking if you could discuss the difference between CCP and IVIG.
IVIG and what? So intravenous immunoglobulin, got that one, but I didn't get the first one.
It says CCP, if perhaps maybe they can elaborate. Not quite sure if.
Well, CCP would be convalescent plasma, but I mean, just to start until we get clarification, you know, there is immune globulin that is just taken from people, and for diseases where a lot of people have immunity, for example, hepatitis A, you can give, you know, immunoglobulin shots, that is IM, and we know that that really is effective in preventing diseases like hepatitis A. That would not be the case here. I mean, you really want to have specific antibody because this is a new virus, and very, very few people are going to have any antibody to this.
Thank you. We did get one more question. I think this could be the last one until we go back to your didactic, but it asked if you think severely ill COVID-19 patients with high flow nasal cannula have a higher survival rate on CP.
I don't think we know. And part of the problem with an expanded access, even though they had 35,000 patients, and I'm sure that they will sort of look at subgroups among those. But part of the problem is in an expanded access program at, you know, thousands of centers, you know, you often don't have a rigorous, consistent reporting of the data. So I think that that's a very important point. I think that also, as I mentioned, you know, sort of the time to, and by the way, the adjustment for mortality also had the time, so whether you got it in April, May, June, or July, because we know that management has gotten a bit better. It's probably multifactorial, and so that was sort of factored in here. But I think, you know, we'll have to see. That's a great question. I think that every time we get something like this that really has promise, and I do think that there is some evidence there for some groups of patients that it absolutely is going to be important. Then the question is, but which groups of patients? And that's why we need the good studies.
Right, and I think the other thing to, you know, consider, the thought is because we still don't know, like, when do we start making our own antibodies, and individuals who may be on ECMO or, you know, ventilated, you know, that were more severe, are they starting to develop that? So I think it does, this is what we were just kind of discussing as well, when you're talking about that severity, at least, you know, what we've found with remdesivir, which is completely different, you know, if we get that started earlier, and I think in convalescent plasma, the thought is a little bit as well, the earlier the better. And so when you're talking about ECMO or ventilated patients that are more severely ill, you know, I think it's going to be really important to also look at that timing of diagnosis and symptom onset, and, you know, at what point are they perhaps making their own antibodies, and that's also helping. And does the CCP give them a boost, or, you know, would they have potentially, you know, started to get better on their own? I think it's a little too early to tell, but I think it, again, to sound like a broken record or, you know, a stuck playlist, I guess is the new lingo. You know, what are we doing to look at those differences in the study to truly determine what is beneficial? Because this is going to be a limited resource. And so, you know, there's been some discussion of, utilizing it in those more severely ill patients, is there going to be a benefit versus if it's a limited resource, giving it to individuals earlier in their course when they're perhaps not as severely ill, that it's going to lead to better benefit.
Well, and clearly, sort of that Kaplan-Meier would suggest that the mechanical ventilated patient who, sort of is on sort of the more advanced stage did not appear, to really benefit. I think one of the things that's so important is that, the worry, I think, at least from NIH, and this is my personal view, but is that this is going to really make it much more difficult to enroll clinical trials. For example, the monoclonal antibody to the binding protein domain on spike, that is a study that is coming out, and there are precedents. For example, Ebola plasma really did work, monoclonals really did. And so, their concern is we need to find out more about convalescent plasma, and will it put a freeze on being able to really enroll these studies. And I would just say, this is not the first time that we've had some glimmers of hope come through, with other things. And what you do is you adjust your studies to then perhaps compare the monoclonal, for example, to convalescent. It's more work, it's a pain, but, I think that the research community, and I'm speaking just, my personal opinion, I'm not speaking for anybody, I think we have to be much more flexible and really adjust those clinical trial designs to really have maximum equipoise. Before we move on, is anyone else on the panel? I could only see 6 Hollywood squares, and I don't know if there's anyone else that would like to comment on the plasma. Okay, well, hearing none, I think we'll move on then to controversy number 2, which is kept life interesting. If we go to the next slide. So as most of you know, the CDC altered their test recommendations to suggest that, persons with symptoms self-isolate, that close contacts defined as within 6 feet of a known case for greater than or equal to 15 minutes, test if they're vulnerable or recommended by state or local health officials. And the third line, no COVID symptoms and no close contact, no test needed. But I think the thing that raised everybody's ire was that, close contacts, if asymptomatic, don't need to be tested. And that was really a bit of a change, because it's been test and contact trace, quarantine. I mean, that's really been the mantra. If we go to the next slide, this was really met with the Infectious Disease Society of America and the HIV Medicine Academy, of which Dr. Feinberg is the president, had a response. And it basically, they were calling for an immediate reversal of the abrupt revision of the testing guidelines, which diminished the importance of testing asymptomatic individuals exposed to COVID. You can read on, this revision is concerning, particularly as the United States continues to lead the world in confirmed cases and deaths. So therein lies the controversy, and this has really been heated. I will say that Bob Redfield has stepped this back a bit, but just to be devil's advocate, if we go to the next slide, this was taken from a paper a couple months ago in the Annals of Internal Medicine that actually looked, it was studies that had been conducted in China. Even if you were asymptomatic and exposed, you were really quarantined, and they did studies doing tests every day. And the remarkable thing about this is that if you look at days since exposure, starting at day 1, the probability of really having a positive test is, the negative tests were almost 100%. And it was really out to about day 4 or 5 before you really started to see, at least half of those folks who ultimately had positive tests having positive tests. And then after, interestingly, about 10 days, the positive tests started to wane and more people had negative tests. And I just put this up because, I think that, and I certainly don't, I think there are reasons to test, but it may have been that, the CDC said this, that, there's a sense of false security. If you're exposed to someone yesterday, get tested the next day and are negative, and then proceed to go about your business without quarantine, without isolation, and without retest, that is a false security that probably the data don't support. And I think that that's true, but I think that one of the important things is until folks realize that they've been exposed and get the test, I would say it's not China, and most people are several days down the road. And I think to not get a test, in my opinion, I think, sort of is not conservative. This is raging. I would be interested with other people's, comments. Where do you sit with this controversy?
So this is Lisa. I can tell you that from a state level, our pandemic leadership chose not to alter our testing strategy and continue to test asymptomatic individuals. I think the point you just made, Dr. Hodder, is one that I continually try to emphasize. Our former state health officer, Dr. Slemp, she would usually say, her thought was like 4 to 5 days after you had that exposure is when you should really consider getting tested. And I think this data kind of supports that mantra, because I do think it's really challenging. And as we move into the school start, that will happen in some counties, it won't happen in others. I think that's going to be a big item. We had a call with pediatricians last night where it was brought up, if there is an exposure, you're quarantined for 14 days. And they were like, well, why are we waiting that long? And it's like, even if you have a negative test, you still need to maintain that quarantine given the incubation time of the disease of what we know. And I think that this data, even kind of further perhaps supports that when maybe people started having symptoms and they would get retested. And so I do think that negative test provides false reassurance that, oh, I tested negative, so I can go about my business. And it's not. It's just you tested negative at that time, and you still need to monitor your symptoms in that time in which you potentially could develop symptoms. I think the other challenging piece with testing is the lag time it's taking to get the results back of it being really any actionable. If it's taking 5, 7, 10 days to even get your result back, you've really lost that opportunity to then make any significant public health intervention. So as we start to discuss other testing modalities such as antigen testing, where we give up some of our sensitivity to allow that rapidity of a result, I think that's going to be interesting to see how we continue to look at the utility of those tests as well. But I can tell you, based upon the state, their approach is to still test. But I think what we saw in the public, people in the public are starting to, I guess, I don't know, I don't want to make assumptions, but the governor announced that we would test athletes in counties that had moved to a orange level on the county map, and all the counties refused to get their athletes tested because they didn't want to get tested, because if there was a positive, they knew that there would be close contacts and they would be 14 days out. So they chose not to test. And I mean, there were coaches who publicly said that. So I think we're now battling also the public understanding of this, and choosing not to get tested because they don't want to potentially have to be isolated or quarantined, which from a public health standpoint is certainly not ideal and opposite of where we need to kind of be going in regards to that mindset. But it's certainly a challenge that we continue to experience, and this, mixed messaging leads to more, I think, confusion and distrust among the public.
Well, I think you're right. I mean, I think these controversies, whether it's the convalescent plasma, which with tit for tat from the NIH and the FDA, or, sort of the CDA and tit for tat with the infectious disease groups. I mean, it is very confusing, but the bottom line is today, honestly, behavior is the only thing we have. Quarantine, social distancing, mask. I mean, that is the only thing for the near future. And I do think that testing actually helps that relative to the schools, some of what's been written about children having more mild disease, more mild symptoms or no symptoms. I think that, when you think about testing, how are you ever going to get a handle on it if you really aren't looking? And the athlete issue, some of the issues that are appear to be arising, and I don't think we know, really have complete understanding of this. As I discussed, some of the myocarditis has been seen in young, healthy individuals. And so, sort of having, not being tested and having the possibility of a complete team or much of a team getting infected, the long-term effects of that are not clear. It's the new virus. So it really is problematic, but I think the controversies and the disagreement and often the politicization has really led to a lot of confusion and angst among the public. And I can understand, it's really, I think, sort of problematic sometimes for people to know what to believe. Are there other folks that would like to comment?
Dr. Hutter, we did get a couple questions in the chat as well.
Okay.
So the first one is sort of a three-part question about testing. So the first part is, what tests fit the operational definition for rapid testing?
Rapid testing are tests that come back very quickly. There has been an ID now test that's been out. That was the Abbott test, and I think that might have been the first one. And that is actually based on a rapid PCR, and subsequently there were reports of even up to 50% of people who subsequently had a positive test having initially negative on the ID now. That was another controversy. The company went back and alleged that the appropriate procedures were not being followed for that test. I know for a fact the National Guard is using it in West Virginia on some of their vans and has actually had, very, very good results with that. But I think that they have a number of procedures and policies that are assuring it's done correctly. Lisa mentioned the antigen test, which doesn't look at the nucleic acid per se, but looks at the antigen. It looks very good. It's, going to be coming out. I think that rapid tests are the way to go for the reasons Lisa mentioned. I mean, if you're waiting 9 days to get a test, why bother? But here's the thing, no test is 100%. And I think we try to improve those, to the level we can, but nothing will take the place of careful behavior if you've been exposed, quarantining yourself, and, really being sure that, you really let everyone know if you do have a positive test so that they can really sort of quarantine as well and prevent spread. And that's going to be important. We're going to see a whole bunch of new tests. You might have read about pooling, and they're working on that at WVU, which is, sort of unlike what's now roughly, $50 to $100 per test. That'll be $5 a test, and pools a lot of samples together, so you can do it much more quickly. If there's a positive, then you have to separate and figure out who's positive. But that's been done with lots of other diseases. So I think we're really going to to, sort of see this moving, and hopefully the tests will not be stymied by the supply chains that have been problematic with, swabs and so forth.
Thank you. So the second part to that question was, what does the data say about the reliability of rapid testing?
Well, that's what I alleged about before. I think that rapid testing is often done point of care. I think I answered that when I said it came out and it was supposed to be above 90%. And in fact, there were reports once it got out in the field that it was 50%. And the company has responded. They're doing, sort of more studies on that. But I think that we'll need to see, most, the PCR, if you truly, are at a time when you have virus, you could see there that actually 15 to 20, 25%, on a single sample, may be negative, and that's just where the test is. And I think that, if you have multiple tests or are tested subsequently on another day, that obviously goes down. And that Annals paper actually addresses that issue as well.
Excellent, thank you. And the last part to this question was, what does the current availability of testing look like in West Virginia and Appalachia, specifically availability and rates of testing in rural areas?
I can answer that, but Lisa, do you want to talk about that?
Sure, I can take a first effort at it. I can say, from really the beginning of the pandemic, there's always been ongoing analysis of what is the testing capacity in state versus out of state. That gets looked at, and it continues to get looked at as we've tried to increase supplies, whether that's swabs, viral transport media is always another issue. Some samples can be run in saline, some could be in viral transport media. As we've just been discussing antigen testing, there's a effort by CMS to put an antigen test in all nursing homes across the country. At this point in West Virginia, we've probably received about 5 from that allocation. I know that there's been a lot of private practices searching to identify antigen testing for their own practices. Our estimate is anywhere from 5 to 8,000, and I don't have the data in front of me, that can be run per day. Then there's other factors that get plugged into that, because even within our own state, equipment can break down, or it can lead to further delays in getting the test result back. And then there's been a targeted effort to go into communities to be able to target testing where we're seeing increase case numbers. So there's been a lot. It was actually started through a work with the Minority Affairs Division to try to better reach out to populations that were being disproportionately impacted and not perhaps getting tested as much. So our minority communities, and then those kind of led further into larger community testing events. But I think it still remains a challenge in a lot of places as supplies get diverted to the federal government, or, I've heard of private practices purchasing an antigen test and then it getting diverted to the federal government because the feds have taken on this a task of providing one of those machines for each nursing home. I've also heard practices say we don't want the antigen test because it takes 15 minutes to run one. We can only do 4 an hour. We can do far more PCR testing than we can rapid test. I think the card-based, rapid test that doesn't require machinery is a lot more attractive for use in a private practice or outpatient clinic area. So I'm not sure if that answers the question. The school public health at WU is an interactive map that puts the testing
locations. But even just today, I got another call about, what is accepted for testing. The community-based testing, anybody can drive up and get a test, but then to still get tested in many of these locations, you need a physician order. And for many places that are doing it, they still want you to meet certain criteria to qualify for a test. And then certainly the whole other aspect that is a whole other discussion to open up is, who pays for it. And I think we're starting to see insurance companies deny payment for some of these tests if there's not a true indication for testing. And so that certainly is something that isn't seen until far after, the fact the person has already received the test, and then it's subsequently being told that it was denied and not covered. So that was a lengthy answer, but it is in the thousands, and it is looked at every day and monitored to determine how can we increase capacity. There's different labs within our state that are working to develop some of their own tests, which I think will be another big game changer, that we'll be able to run more in our own state, because some of these labs commercially are located in areas that then subsequently got really hard hit. So Texas, AIT is in Texas. So when Texas was seeing their big spike in cases, obviously when you're talking about samples from West Virginia, the local samples usually tend to get put, more to the forefront. So that's been an ongoing discussion and point of analysis to determine, what is the turnaround time in some of these commercial labs.
So I agree with everything. A couple of things I would add. Yeah, I think, the asymptomatic, we know 40% of people are asymptomatic. So, back to the CDC quandary, the, exposed asymptomatic person, actually most insurances won't cover that, and it is not cheap. So that's a real, I think, barrier. CMS is saying, oh, they're going to give everybody a test. That's not, clear yet. I think that's not the answer. West Virginia has, I think, done well. I mean, as Lisa mentioned, you go on the DHHR coronavirus and they have, sort of percent tested versus other states. West Virginia was the first state that the governor mandated to test all nursing home patients. And I think that really was very important. But there's some stuff that I think is going to change the paradigm. As I said, actually WVU is working on this pooling thing, and it's not just WVU, it's working, with others in the state. But there's also, came out this week, I'm trying to think where, there's an entrepreneur that is really trying to market a home test. You brush your teeth every day, you do your COVID test every day. That might be a game changer. And LabCorp actually has an EUA for a home test, though it's expensive. It's $120, but they turn it around once you mail it in a day, which is very quick. So I think that some of these home testing to make it easier, particularly if they're cheaper, I think that's really going to be the difference.